Good morning and welcome to the 22nd Annual Northwest Patient Safety Conference. You've joined the session partnering with patients and families to enhance safety. I am Valerie Harmon. I'm the Executive Director at the Oregon Patient Safety Commission, and I'm so glad that you've all joined us today. Before we get started, I have a couple of housekeeping items. First, all presentations are being recorded. We'll be sharing this presentation, the slides, and speaker contact info on the conference website after the conference. We'll also be sending out continuing education credit info, so please look out for that. We do have time for Q&A at the end of the presentation. Please feel free to use the chat feature to add your questions whenever they come up, and we will get to those at the end of the session. And now it is my great pleasure to share a little bit about our speakers today. First, we have Beverly H. Johnson, who is the president and CEO of the Institute for Patient and Family-Centered Care. She provides training and technical assistance for advancing the practice of patient and family-centered care and creating effective partnerships with patients and families across North America and beyond. Bev has served as a member of the selection committee for the American Hospital Association Quest for Quality Prize and the board of directors for the Association of American Medical Colleges. In 2017, Bev was recognized by the American College of Physicians with the Edward R. Loveland Memorial Award. In 2018, she was recognized as a fellow in the American Academy of Nursing. Bev is joined today by Peter Tarsa, who is the co-vice chair of the Beth Israel Deaconess Medical Center's Patient Care and Quality Assessment Committee, which he has served on since 2014, when he was appointed as one of the first patient advisors to the committee. Prior to and during that time, Peter was a member of the Hospital-Wide Patient and Family Advisory Committee, or PFAC, chairing that committee from 2016 to 2018. As a continuing patient at Beth Israel, he remains a passionate advocate for the voice of patients in matters related to quality and safety of care. In addition to his role at Beth Israel, Peter works in therapeutic area strategy at Novartis. There, he has worked across multiple drug discovery areas in roles of increasing responsibility over the past 2 decades. Peter is a graduate of Wake Forest University and holds a PhD in chemistry from Princeton University. He lives in Marshfield, Massachusetts with his wife and 2 daughters. Wow. I am so excited to hear from both of you today. So now please join me in welcoming Bev Johnson and Peter Tarsa.
Thank you so much, Valerie. And I am just delighted to be here with all of you, and particularly with Peter. And I hope that you were able to hear one of the previous presentations about partnering with patients and families from our Canadian colleagues. A wonderful, thoughtful presentation. And we're delighted to have an opportunity to share information with you as well. I hope that the Institute for Patient and Family-Centered Care will be an ongoing resource for all of you, both in the United States and Canada and countries beyond. IPFCC, as it's known affectionately by many people, has lots of information and resources. We try to share best practices to make it easier for you to partner in meaningful ways and really to integrate the core concepts of patient and family-centered care in all aspects of healthcare, and really in all settings. So I hope that that will be useful to you. It has been such a pleasure to get to know Peter and working on this presentation. I have respected from afar the work at Beth Israel Deaconess Medical Center for many years. And this just has helped me grow in my understanding of what makes partnerships work and why they are so essential to building a safe, collaborative healthcare system. Today, in our time together, I hope that we grounded all the work in partnerships with patients and families, and we will do a very brief overview of the evolution of the patient safety movement, and really how partnerships with patients and families really shaped that movement from the very beginning over more than 30 years. Um, I hope that we leave you with some concrete ideas about how to partner with patient and family in safety work specifically and reducing harm, and that we will model partnership and describe strategies to make it truly effective in meaningful work. I like to do all of our work really reminding myself and others about the core concepts of patient and family-centered care. These core concepts were developed many years ago in partnership with patients and families, clinicians, and staff. And they've been tweaked over the years, but the core basis of them has remained the same. And we like to think of patient and family-centered care as an approach to the planning, implementation, and evaluation of healthcare that's grounded in mutually beneficial partnerships. Our healthcare systems have to work for everyone, for patients and families, but also for staff and clinicians. And there are 4 core concepts. And I hope going forward, you might use PFCC in these 4 core concepts, even just those key words at the beginning of meetings. So you ground yourself in this approach to discovery and to planning and in facilitating discussions. The first core concept is people are treated with respect and dignity. That's all people, not just patients and families. It's up and down the hierarchy of the organization. The second is that we share complete and unbiased information with patients and families in ways that are affirming and useful. Third, it's participation, that you encourage and support patients and families in care planning, and decision-making at the level they choose, so that you work with them where they are and gradually build on their confidence and competence to be true partners in care. And the collaboration is not just in clinical care, it's in the quality and safety work that we're talking today, which is integral to policy and program development, professional education, research, innovation, and the delivery of care. As I mentioned before, we wanted to ground our conversation with you today in these early partnerships that were so essential in shaping the patient safety movement. A tragic incident happened in 1994 when Betsy Lehman, who was then a young mother and the health reporter for the Boston Globe, died of a massive chemotherapy overdose. And she was at Dana-Farber Cancer Institute, and the organization promised from the very beginning that they would change the culture of the organization and learn from patients and families and share that learning and process of change across the world. And to this day, they have honored that commitment. And Betsy Lehman's family helped them understand, how they really didn't listen to her when she said, "This just doesn't feel right." So that was the beginning. And then several years later, Eileen Corina's son died from a simple tonsillectomy. And this was her first child, much wanted, beloved Mikey. He was less than 3 years old. And his mom had trusted the healthcare system, didn't know how involved she needed to be as truly a partner and advocate for her son. And she so generously began to share her journey of learning and founded in 1996 the Pulse Center for Patient Safety Education and Advocacy. And using her experience and her learning, there's a powerful video online that you might further understand her story. But to this day, she is still working as a partner for change and teaching health professionals and people in the community about the importance of these partnerships. And then several years later, Josie King, a toddler, died tragically of sepsis at Johns Hopkins. And again, the hospital responded that we need to learn from this tragic incident and from the family. And her family was very generous in establishing a foundation, in writing a book and creating a video to help us learn from what happened in that and to try to prevent harm in the future. So they really established this notion of patient and family partnerships. Go forward a few more years, and while this article is a little over 15 years old, it's one of my favorites in terms of it captures the thinking of these key leaders in patient safety. Lucian Leape, the father of patient safety, Don Berwick, who formerly CEO of the IHI, and Carolyn Clancy was head of the Agency for Healthcare Research and Quality that had such an emphasis on patient safety for many, many years. And Jim Conway, a wonderful visionary hospital executive who truly understood partners. And if you could think of what they said as critical to transforming our healthcare system, we envision patients as essential and respected partners in their own care and in the design and execution of all aspects of healthcare. In this new world of healthcare, organizations publicly and consistently affirm the centrality of patient and family-centered care. They seek out patients, listen to them, hear their stories, and are open and honest with them and take action with them. That's what these partnerships really look like and can mean to your organization. So how do we make that real? And let's see if we can move these slides along. I'm going to go back one. There we go. The slides just got very enthusiastic. After Betsy Lehman died, there were many people that honored her legacy, and the Betsy Lehman Center was created to focus on patient safety. And while it's a tremendous resource in the state of Massachusetts, it really does have an impact nationally and internationally. They have a wonderful newsletter that's free that I urge you to subscribe to. They have many webinars and other information that would be useful. And about a year ago, they published in the August issue a very clear explanation of the new CMS patient safety structural measure. This is in the United States, provides really a safety practices and a framework that should be present and which will in the coming year be publicly reported by adult hospitals. while it's a US expectation for about 5,000, the really overwhelming majority of our hospitals, it really could serve as the standard across borders and across all types of hospitals, including children's hospitals, rural critical access hospitals. So I think it's a very important substantive strategy and really a sense of accountability of what we need to build into our hospitals and health systems. In the spring, following that newsletter from the Betsy Lehman Center, IPFCC created a toolkit to really help hospitals implement these partnerships in a substantive way and help really understand what the structure was trying to do and to share best practices of what others were doing. So one of the expectations was every hospital should have a patient and family advisory council. I'll use shorthand. We often refer to them as PFACs. And in addition to having a PFAC, they expected that patient and family partners would be at board meetings. They would consult on safety goal setting and metrics and participate in safety improvement initiatives. They also said strongly that patient and family advisors should reflect the range of communities served, and that is important work that needs to happen for many existing PFACs, but also those who are being created now from the beginning. So what I'd like to do is share with you what Peter has learned from his beginning journey and have you be inspired by this wonderful patient partner.
Thanks, Bev. Just before I start, I should also just, Valerie mentioned, I'd like to just, in full transparency, share that I work for Novartis, a global pharmaceutical company, but I'm here today in my capacity as a patient and patient partner. So with that, maybe we talk a little bit about my experience with the Beth Israel Deaconess Medical Center, PFAC, and how my journey started. It actually started before the suggestion box. Just to go all the way back to 2011, I showed up as a early 30-something who had hadn't seen a doctor in about a decade, but was very, very sick, and spent 3 months in the hospital as a leukemia patient, and wound up with a bone marrow transplant that really kicked off my patient journey at Beth Israel. For those who don't know, bone marrow transplant is curative for leukemia, so the cancer is gone, but it leaves you with a number of other side effects that keep me coming back, unfortunately, to the medical center. In one of those visits back, maybe 6 months later, I was sitting in the clinic waiting for my appointment, and there was a suggestion box with a card that says, "How has your care been? And do you have an opinion?" And of course, I did. I'd been a frequent flyer already. And was going to be going back quite a bit. And so I put my name down, and they called me up and said, "Would you like to join the PFAC?" This was a hospital-wide patient family advisory committee and essentially a standing monthly almost focus group where the administration would come through with initiatives that were happening or looking for input on things, everything from a care cart that would go through the clinics to major initiatives like transitioning to new form of medical records. What I learned quickly was that to be effective, the PFAC really had to represent the patients that the hospital was serving, which means not just demographically, but people of all different walks of life. And that meant that sometimes people would come and advocate for their own specific story. The best PFAC members would think broadly about how their story fit into the big picture for the hospital. But a key to all of that was the facilitator. And so it was one of the take homes I definitely wanted to leave you with today was this importance of a a facilitator who's inclusive of all voices and gets the best out of people so that you know, the voices can be heard and we can work together as a group to inform um, hospital needs. Another important part of the PFAC at Beth Israel was the attendance of senior leadership. And so, you know, the chief nursing officer was there every single meeting. The co-chair, the committee was co-chaired by one of the lay members, as well as the head of the social work department. And we had a number of senior executives who would come through on a rotating basis. I remember when Kevin Tabb was appointed CEO of Beth Israel and eventually Beth Israel Lahey, he was sure to come and make a visit with the PFAC. And we've gotten to know all the new leaders as they come in, and they get to hear the perspectives of the patients that spend so much time in the hospital there. And then the third thing, just to make sure, you know, engagement is high and you know, the PFAC is used well, is just to make sure that substantive topics are discussed. And so, you know, everybody there, regardless of where they come from, is donating their time in doing so with the intention of making a difference for the hospital and for future patients. And so, you know, the topics that go in front of that committee are so important, just to make it worth it, not just the PFAC members, but also the hospital and the executives who turn up. So, you know, that's just a few thoughts about the PFAC. I was on it for a 4-year term. Towards the end, they nominated me to chair it, and they actually were kind enough to extend my term. So I spent 6 years on the Beth Israel PFAC. And after that, was nominated to join a board level committee, which I'll talk about in a few minutes. But maybe with that, back over to Bev.
Thank you, Peter. You know, you shared so many pearls about what makes this group successful, and thank you for all the time that you've put into that work to really partner in a significant way on, as you say, significant topics for the organization. In talking with Peter and thinking about what we would talk about today, I thought of some of the work that had been happening at Moffitt Cancer Center. And there's a profile on our website that describes some of it over a number of years. They've been very committed to patient and family-centered care, and specifically to having a robust and really innovative patient and family advisory council. I think about how at Beth Israel Deaconess, Peter described how new senior executives come to the PFAC. What a great part of the orientation, really profound. And at Moffitt, on a regular basis, I would say more than 9 to 10 senior executives attend the PFAC meeting. They're really there to listen and to discuss issues as they emerge. And one of the things they do, which I think is really wise if you're thinking about developing a template for your PFAC advisory councils, is to have some time there to bring up issues from current experience, so that it may be something that the patient or family advisors share. It could be, like at Moffitt, they train some of their advisors who are interested in becoming peer visitors and participating in what they call coffee connections, so that they are meeting and providing peer support to a number of current patients. And it broadens their understanding from a patient and family perspective, what's happening at the organization. So they can bring up issues, and the leadership hears these issues in real time, and they may comment, we think this is something we should look into and that we can learn so we can make it better for all patients. They're not just trying to fix this for a patient and family advisor, but more broadly. And the PFAC keeps a log of these issues. So it's not just we bring it up and it just floats away in the atmosphere, but that there is some accountability to following up and seeing how it's addressed. So in some ways, it's closing the loop But it's making sure that these things are tracked meaningfully and are resolved. So there are many other pearls that you can learn from Moffitt in that profile. With the new CMS patient safety structural measure, many hospitals are really either strengthening their PFAC and PFA program, or they're actually starting it, that maybe they had one before and it wasn't facilitated correctly, or it just lost interest, or for whatever reason, they're having to start all over again or start for the first time. And so we have a very simple one-page checklist. It's a writable PDF that you could use to either start and think about some of the things you need to do to build the infrastructure of a meaningful PFAC and PFA program, or if you want to really just strengthen aspects of it. So you look to see, perhaps you don't have an executive sponsor, or nobody got around to writing a charter or bylaws, or you really need to re-look at your recruitment strategies. You're not recruiting advisors that reflect what your demographics show you, that you really should be representative of the broad diversity of populations and communities that you serve. One of the things we've found useful, and if you're getting started for the first time in developing a PFAC and PFA program, to look for some informal advisors that might be willing to work with you for 6 or 12 months just to develop the program. And we actually used this after the Betsy Lehman tragic death at Dana-Farber, that we said, we'd like to work with you for a while. We're not even going to develop a structure for a council yet. We're just going to learn to work together and build some trust. And neither one of us are going to commit to working together forever. This may not be of interest to you, or we may find that this way you work is not compatible with partnerships. So we would learn from each other from the very beginning. This can be extremely helpful. I saw this just done beautifully in Ontario, Canada, a number of years ago, where they really created the program from the beginning with this partnership. So I hope this tool, it's really just one page, has some key touch points for you to think about as you develop and enhance your program. I think also in talking with Peter, I was reminded of the importance of listening sessions. If that one-page checklist just overwhelmed you and thought, with everything we're dealing now, we can't do all of this, just get started and listening to patients and families. And it could be one patient. I had a wonderful conversation with a family advisor in thinking about some of this session today. And she told, I learned new insights just in talking with her about where she didn't realize she had to be involved in her loved one's care as much as she really needed to be. And that was a learning that could have happened from the very beginning if a physician or nurse had really said how important her perspective and her voice was. I think also years ago, I heard of a hospital that they invited all of the families who'd lost a patient in the ICU in the last 2 years to come to a meeting, a listening session. They had very skilled facilitators. From the beginning, it was intended to be a supportive, healing environment, but an environment of learning, that families could learn from each other and that families could share insights about what was helpful in that experience and what was not helpful. And it turned out a wonderfully successful meeting, that they identified some people who would like to continue to give back and became advisors. So that listening session became really a recruitment strategy, as well as something that was healing and supportive of people. So think about that. PFCC Partners is a wonderful organization in California, and they are really have a lot of expertise about it, and they've created the ACT framework. So another resource to help you in your work. At Luminous Healthcare in Maryland is a small healthcare system with 2 hospitals, and Anne Arundel Medical Center is in Annapolis. Here's some other pearls of best practice for you. The president, chief nursing officer, chief medical officer attend on an absolute regular basis all the PFAC monthly meetings. They have multiple PFACs. This is the acute care main PFAC for the hospital. They also have 2 patient and family advisors who are full members of the board level quality committee. So that's important that they're prepared, supported, and have become full members. And to realize the importance of their role, they have recently changed so that their report is the first item on the agenda of every one of these board level quality committees. And they have 2 slides where they bring updates and issues from the Patient and Family Advisory Council that really serves as a hub for all the PFACs in the organization. And they have one more thing that I think is quite unusual. And if some of you know of this in your organization, they do a daily safety huddle. They call it the safety call. And a PFA attends virtually every one of those daily meetings. They also, not only do they talk about risks and potential harm and how to assure safety, they use it as celebration, as way to nurture the culture of the organization. And I want to share one more example from a health system. The Medical University of South Carolina has long been committed to patient and family-centered care. And their director of really best practice is she reports to the chief quality officer. This is really important to ensure that PFCC and these partnerships align with the safety and quality work. And recently, they started a initiative to focus on hospital-acquired infection. And she reached out to the 16 PFACs in their healthcare system and sent an email and said, would anybody be willing to share their story with hospital-acquired infections? And immediately, 9 patient and families responded. So I want to share with you a quick 1 minute and 21 second video that the advisors made from their cell phones.
My daughter experienced a hospital-acquired infection at her G-tube site during her cancer treatment.
Father had surgery to repair an aortic aneurysm. Several days later, he tested positive for MRSA.
While inpatient, my son contracted MRSA from another patient on the same floor that he was never in contact with.
While she was undergoing chemotherapy. The site was infected for a couple of months before it finally healed up. But due to the nature of her treatment, we were required to continue pressing through despite the infection.
For our son, who was already really medically fragile, this diagnosis was particularly frightening to my whole entire family.
I felt helpless and unsupported by his doctors.
Luckily, through the great care of some amazing nurses and the hospital staff, we were able to get that healed up after a while. But it was obviously a difficult experience to go through.
He quickly became unresponsive, and 3 weeks later, he died. According to the surgeon, from the infection and not the procedure.
This infection was preventable, especially with the proper contact precautions, hygiene, and disinfection usage.
Thank you for letting me share my experience.
So I think this is one way that you can bring partnerships to just set the tone for the work that they're going to do together with a video such as this. So Peter has insights to share about his work at the board level. Peter?
Yeah, thanks, Bev. And that video just resonates so much, not only because in my new role in the PCAC, I'll explain that in a minute. We look after hospital-acquired infections. I actually remember getting a central line infection as part of my original treatment, and among months of chemotherapy and a myeloablative bone marrow transplant, having that central line removed while it was infected was by far the most painful thing that happened to me. And hearing the patient voices and having that really hit home is not a medical thing, but actually a personal and painful thing, whether it's pain or death, is so important. As I said, we look after this after such infections now on the PCAC. This is the Patient Care and Quality Assessment Committee. After chairing or actually in the middle of chairing the PFAC at Beth Israel, I was invited to join the PCAC. They were looking to bring patient voices to this board level. It was a subcommittee of the Board of Trustees. And so, I said, sure, I really was looking forward to expanding my impact on the hospital and having a different lens on things. I also found myself sitting around a boardroom table, not to be trite, but with a bunch of people wearing suits and me, and found that the easiest way to get started was just to bring the patient perspective. This is why I was invited, and it was where my heart really was. We in this committee we do a range of things all through a quality and safety lens. Hearing about and reviewing hospital-wide initiatives. We do a medical peer review where we look at all safety incidents since the preceding meeting. And I found the best way for me to impact originally and still today was really just to ask, did anyone ask the patient? And was the family present to be a partner? And I think that often gets the medical staff to sort of pause and think a little bit. I'm glad to say that over a decade on this committee, I ask the question less because they now reflexively do it, but it's it's a really impactful way to connect this a patient and family advisory committee where people are really coming in to talk about their experiences and their opinions to again board level mission of the PCAC. And so I was asked to co-vice chair the committee last year, and I'm sitting in that role now. And so it's also an interesting way to think about where does a PFAC representative go in the long run. So I hold myself up as an example of that. But Bev, back to you.
Great. And, it's wonderful to see there are a variety of ways that people can serve and grow and learn and have a greater impact for this partnership work. Peter and I also talked about open notes, which is one of the expectations in the CMS patient safety structural measure. How do you share clinical notes with patients and families? And again, from the beginning, with that change, patient and family advisors should be part of that process. And they should be not only part of training clinicians how to do that meaningfully, but how you let patients and families know and how you help them use it effectively, and certainly shared access. So a family member can also, with your permission as the patient, that should be part of it and helping that happen. I think you had other thoughts too, Peter, about the impact of open notes.
Yeah, I mean, open notes is such a cool addition that being a patient, I've experienced it both as a board member and as a patient myself. But it's really hard to talk about open notes without just underlying or underscoring the importance of trust in both directions. I think the doctor who writes the note has to trust that the patient will read it and respect that the doctor is still the final word on on what it means. Medical notation, having done this for a long time, I still don't fully understand, and yet it's tempting to not go to WebMD or Google to figure out what it means and try to interpret it yourself. And so, although I'm sometimes guilty of that, as the patient, I also have to trust that the provider who has written the note will fully debrief me and put it all in context. And the open note, I think, is both a really nice historical record of what happened and a preview of what's coming. When used best, it allows you to prepare for these interactions with either the provider or the patient, depending on what side you're on, in a way that it allows you to ask more informed questions and really understand the care that you're getting and the diagnosis that you have. So I just want to, it's such a great addition to the care toolkit. But again, trust is central to making it work the best.
Great. Thanks, Peter. And so another aspect of Domain 5 in the patient safety structural measure is really a core concept in safety, and that is that supporting the presence and participation of families or designated care partner, whomever the family designates as their care partner, and their specific activities that we have seen over the years that are really important to assure quality and continuity of care. Bedside rounding, change of shift reporting at the bedside, discharge planning that really includes patients and families. And I don't like the word visit or visitation, but what they are saying here is family presence or the presence of care partners 24 hours a day. You have some thoughts on this too, Peter?
Indeed. Yeah, I mean, again, 14 years ago, I stumbled into BIDMC. A lot of the things that Bev has talked about today were not in place at that time, and I had a few, we'll call them mishaps. There was an example of the doctor who was not my regular doctor rounding without the nurse manager present or my nurse present, without my family partner present, and incorrectly told me that my cancer had come back. And you can imagine what that's like to hear and sit with and not be prepared to either put it in context or ask good questions. That was corrected, of course, when the right people were informed about it. But those things used to happen in my patient experience since certain aspects of care remain in place and are strengthened to make sure that kind of thing doesn't happen anymore. Nursing consistency, being a very sick blood cancer patient is on one hand horrible, but you're also quite privileged to have your own personal nurse who looks after you. If you can't do that, just having consistency in who's in front of you, I think is really important to build a relationship and trust, and it heads off some of the safety issues that could otherwise happen. A family or advocate present always for bedside rounds, otherwise present as much as possible. When I wrote this, Bev also pointed out, I didn't know this, that advocate is actually out of fashion and partner is more in fashion now. I think it's such an important turn of phrase. My wife was by my side for my own initial inpatient experience. You could have called her my advocate at the time, but we were definitely partners in all of this. And such an important point of that whole journey for me. And then communication transparency. I think things happen. Being open about them, about what happened, why, how it's going to be fixed. That goes all the way up the hospital system. I believe Beth Israel does actually has a system for apologizing for these things and making amends before people get litigious or when things are really bad. So there's a way to institutionalize that I think is really constructive and lets everybody feel like they walk away from when things inevitably go wrong, with a good feeling about that it was a true accident and shouldn't happen again. Yeah, it's worth just pointing out that as we talk through these things, it's not that we have necessarily a broken system we're trying to fix, but that this, continuous improvement, and hope we impressed upon you that it can start as simple as showing up at a boardroom full of suits saying, did you ask the patient? Or just, showing up and listening. Bev, as you were talking about listening sessions, it reminded me of my drive home. I pass MIT, and there's a kid who sits out on the front steps with a big poster board that says free listening. It can be that simple. Actually, just acknowledging that you're there, curious and wanting to hear from the patients is a great way to just get started. So.
Thank you for those wonderful insights. There's an interesting article that just was released earlier this month, published in Medical Care, the official medical care section of the American Journal of Public Health. And it's a multicultural study. It was done in pediatrics, but we use the term family-centered care and patient and family-centered care interchangeably in pediatrics. Excuse me. And what it was doing was asking what was the current leadership of hospitals' understanding of family-centered policies and practices. And one of the significant findings was that those hospitals with an active PFAC had significantly higher family-centered care ratings than other hospitals, and suggesting that engaging families at that organizational level is valuable. What I think is important is it also, in a lot of the open-ended responses, we learned that there was a lot of variability across units and departments, particularly about those practices like rounding and change of shift report. Oh, we do it on this unit, but we don't do it on that unit, et cetera. And I think it speaks to how important leadership is, and to really totally change the culture of the organization. And study recommendations talked further about additional ways to partner with patients and families, such as in the education of clinicians and staff and quality improvement, and really aligning it with the current accreditation standards. Particularly, that's very clear in the education of physicians. There's an assessment tool that you could find useful in research or quality improvement. So this concept of partnering with families, not labeling them as visitors, this took a step back during COVID. I want to be honest with you on that, but we learned that we caused harm, both for staff and for patients and families, by overly restricting and not really sharing best practices on public health science with families, so there could be some family presence. I'm sure it had to be scaled back some, but not like what we did during COVID. One of the things we learned in that was that early on, when we launched this international campaign, that the American Society for Risk Management really said that supporting the concept of families as partners is proactive risk management. Think of that, proactive risk management, to have a family or care partner present. So I hope that you will think about the language your organization uses, and that you will think that how important they are in transitions of care, in that continuity of care, and that really in contributions for mental health and well-being for really all, not just patients and families, but staff as well. I wanted to in before we have questions. I'm really eager for comments and questions that Peter and I are happy to respond to. There are a number of resources that might be helpful, particularly as you change from family presence and change toward family presence and participation. On our Better Together website, we have guidance for rounds, how to do that collaboratively, and it doesn't have to take more time. And you can use telehealth. We learned that in COVID. So there's some very specific guidance for you. A wonderful organization in Canada is the Ontario Caregiver Organization, and they have this amazing essential care partner support hub with a great evidence report and very powerful video about how to really involve care partners meaningfully and to really change the culture of your organization. Another great Canadian organization that we've partnered with over many years is Healthcare Excellence Canada. And they, during COVID, well, for a long time, but particularly during COVID, they had a wonderful program where they developed the Essential Together Change package. And it's very relevant today with great tools, both for acute care and long-term care. And here's some others. I think maybe Steve put this on the conference website just so you can reach out to other resources that may be useful to you. In about 2 weeks, we're going to do with Liz Crocker, who's an amazing interview. She's going to interview 2 family leaders to talk about their almost 20 years of leading this work for a hospital and really understanding supportive executive leadership and patient family leadership. And I hope that some of you will decide to join that and bring your executive leaders, because we know that this is so important how they support these partnerships. And here's some other resources as well. So Peter and I thank you so much, and we're here and we're happy to answer questions. Please reach out if we don't answer your questions today. Thank you, and back to you, Valerie. I think.
Yes, I can speak. I can't quite turn my video on. I think that might be a host.
You're
Oh.
here in
All right.
spirit.
Oh, there I am. I know. Technical challenges. Here we go. Thank you both so much. Really appreciate all of the content that you shared. It looks like we do have a couple of questions in the chat. The first one is for Peter. Peter, you mentioned participation in medical peer review. Historically, this process has been closed to non-physicians, and legal protections have been reinforced or have reinforced this closed door approach to retrospective review of clinical decision making. Can you describe for us a little more about how resistance to involving patient and family partners in the medical peer review process were overcome, and how that perspective of the patient and family have impacted the approach in evaluating errors in medical care? I know that was a mouthful.
No, it's a great question.
Yeah.
I glazed over that point. It's really important. A big part of my onboarding was a reiteration of what medical peer review means as a term, and the fact that there are there's a legal aspect to that term. And so the other side of that, I in a different context during our talk, I discussed trust. I think the medical center took the leap of trusting us. And in return, I think we've honored that trust, not only by keeping that review within the confines of the committee, but also I think asking constructive questions and being open where we don't understand certain things. I think medical shorthand is not interpretable by a layperson. And I frankly think that we've gotten to a better place from that. I can remember cases where there were medication errors. You can, depending on the patient, I'm, as a consequence of my transplant, I'm diabetic. I'm a highly skilled insulin injector right now. And I think if you give me the wrong thing, I at least you could ask me if is that injection really large, or is that pill the right one, or simple things that are very patient-centric but central to quality have come out in those types of reviews. And I see that as part of my job in that room to do so, within the framework that they put in front of us.
Yeah, great, thank you. We have a couple of other questions. We'll see if we can get to them. And I think for either you, Bev, or Peter, any thoughts about how to really recruit that diversity of perspectives on the patient and family advisory committees that you talked about? Like any tangible things folks can think about doing?
Absolutely. That is such an important issue. And I think one of the things that you can do is contact the departments in your hospital, for instance, that are building community engagement. They might have been called diversity, equity, inclusion before. They could be around community partnerships. And I would seek the demographics for what's the data? Who does your hospital serve? And then look at what are some groups within those different regions and develop some partnerships. Hold some listening sessions and town halls in different parts of the community where they feel safe. In January, we will have a brand new toolkit released. It's been used by 2 large learning communities for almost the last year. And it's all on really having your PFAC and PFA program really collaborate meaningfully with the broad range of communities you serve. So there'll be lots of tools there, but I think that's a good start. I don't know, Peter, do you have some other thoughts?
I mean, maybe to add to that, what was very powerful for me was a one-on-one phone call where it was a safe space and someone was curious about me, and I was able to, share with them my own journey. And so everything Bev said, but I just don't lose the personal touch as well. I think that's always key to recruiting a good committee.
I have we probably have time for one final question. I don't know if we're going to get to all of them, but this came on a direct message. You mentioned, Peter, specifically that it was so important to really assert the fact that the patient and family voice needed to be included in those decisions when you're in this room of suits, right? How do you deal with that? It feels like there might be a little bit of an imbalance of power there. That would be tough to really find your voice. Any parting words or guidance for everybody thinking about how to do this?
Yeah, I mean, there is an imbalance of power. Although the way I look at it is by having no power, I maybe have infinite power. I have nothing to lose. The worst that can happen is they can ask me to leave, and instead they keep asking me to do more. And so I dip my toe in the water gently at first, and on positive feedback, have sort of gotten a little bit more courage. Now, I mean, you can't lose sight of the fact that I have been doing this for over 10 years now, and it took a long time to get comfortable. I just by coincidence had dinner with a few of my co-committee members last week, and some of them in that moment were vulnerable and said, yes, they felt uncomfortable speaking up too. And so, I part of it just, it does take some courage. Part of it, is reading the room, and, part of it is just doing it. The other side of that though, that patient voice is so important to me, and that patient and family partner voice. A story I didn't find the right time to share, but I will just throw in here at the expense of time, unfortunately. When I showed up at the hospital, very, very sick, my wife was told not to go home because I might not make it through the night. Now, what I didn't tell you was that she was also 7 months pregnant, and we had all of her neonatal care moved from a different hospital to Beth Israel. She delivered by induction in between my chemotherapy and my bone marrow transplant. And to give you a sense of how focused the institution is on the patient at the expense of the caregiver. She will never let me forget. In the labor and delivery room, the nurses made sure I was comfortable first. And you can only imagine how just, how mind-blowing that is. She was a good sport and our daughter turned out great. She's now 14 years old, exactly how old my transplant is. But, to me, that underscores the importance of having a voice and speaking up and, making sure that not only is the patient cared for, but the family partners are heard and part of the whole process. Is just such an important part of, when I sit in that boardroom, just remembering why I'm there and doubling down on that. So
Thank you. Bev and Peter, we're so grateful to you for sharing your time with us today and your expertise. Really appreciate you. Thanks everybody for joining us. The next session starts at 11:45, so we'll see you there. Thank you all. Appreciate it.
Thank you so much.